Hey there, future healthcare heroes. Welcome back to the deep dive. Today we're diving into the body's magnificent yet incredibly complex internal communication system, the endocrine system.
Mm.
Imagine your body as like a finely tuned orchestra, and hormones are its conductors. When those conductors miss a beat or the tempo goes wildly off, well, the whole symphony can unravel, impacting everything from your energy levels right down to your heart. Our mission today is to give you a powerful shortcut, sort of extracting the most crucial nuggets of knowledge about endocrine problems. We're pulling directly from Lewis's Medical Surgical Nursing, Assessment and Management of Clinical Problems, specifically zeroing in on what you, as a nursing student, truly need to grasp, not just for your exams, but for real patient care.
That's absolutely right. We're going to unpack these conditions by guiding you through the pathophysiology, understanding the risk factors, identifying those key clinical manifestations, touching on diagnostic tests, and maybe most importantly, detailing the crucial nursing management. Our goal is really to make complex medical terms click, highlight the nursing process, and integrate some real-world scenarios so you can see how this knowledge applies in practice, especially as you gear up for things like the NCLEX.
Exactly. We'll be focusing on three of the most impactful endocrine sections of our body's orchestra: the pituitary, the thyroid, and the adrenal glands. So let's get ready to understand these hormonal regulations and discover why they matter so profoundly in patient care. Okay, let's begin with the master gland itself, the pituitary. It's tiny, right? Smaller than a pea.
Incredibly small.
But its hormones, particularly antidiuretic hormone or ADH, are absolutely critical for maintaining fluid balance in the body. So when ADH gets completely out of sync, how does that typically manifest? What are the key opposing conditions we often see?
Well, what's fascinating here, and really important clinically, is how two conditions, syndrome of inappropriate antidiuretic hormone, or SIADH, and diabetes insipidus, both stem from ADH dysfunction, but they create dramatically different, almost opposite outcomes for the patient's fluid and electrolyte status.
Okay, two sides of the same coin, basically. So let's start with SIADH. If we're talking about an overproduction of ADH, what exactly does that mean for the body, like at a cellular level, and how does that mess with the fluid and electrolyte balance?
Right. In SIADH, the body inappropriately reabsorbs too much water in the kidneys, even when it absolutely shouldn't be. This leads to an increased fluid volume within the bloodstream, but here's the really critical part. It dilutes the sodium in the blood.
Ah, okay, dilution.
Exactly. So you'll see fluid retention, a low serum osmolality,
Okay.
and what we call dilutional hyponatremia. The kidney is essentially hoarding water, which leads to a low urine output with a high specific gravity. This dilution of sodium is truly the hidden enemy here.
Makes sense. And what are some of the common triggers or underlying causes? What makes the pituitary go into this overproduction mode?
Well, cancer, particularly small cell lung cancer, is a frequent culprit. You see it quite a bit with that. But also head trauma, certain medications, think some antidepressants or antipsychotics, and even some infections can induce it.
Gotcha. So if a patient's body is holding on to too much water and diluting its sodium, what are the red flags? What are the actual things you, as a nurse, might observe? Maybe walk us through a subtle presentation where SIADH should pop into your head.
Sure. Initially, symptoms can be pretty mild and honestly easily missed. Think thirst, maybe a little shortness of breath with activity, fatigue, some muscle cramping perhaps. But as that serum sodium drops, especially below 120 on EQL, that's when it becomes a severe high alert situation.
Okay, 120 is a critical number then.
Definitely. Below that, you'll start seeing vomiting, abdominal cramps, muscle twitching, and then signs of cerebral edema that can escalate quickly to lethargy, confusion, seizures, and even coma. And what's tricky sometimes is a sudden weight gain without visible edema.
Oh, interesting.
Yeah, so imagine a patient complaining of maybe a persistent headache, feeling unusually tired, maybe a little confused about the day. You check their intake and output, and they're barely urinating, but their daily weight is up a kilo from yesterday. That pattern should immediately make you think SIADH.
Right. Okay, given those high-stakes symptoms, what are our absolute priority nursing interventions? What do we do first?
Fluid restriction. That's the cornerstone of management, often as low as 800 to 1,000 millimol per day total.
That must be tough.
It is. So as nurses, you'd be constantly providing frequent oral care to manage their thirst and, just as importantly, making sure they understand why this restriction is so vital. Now, if that severe hyponatremia with neurological symptoms occurs,
The confusion, seizures.
right, then small amounts of IV hypertonic saline, like 3% sodium chloride, might be administered. But this is a high alert medication.
Okay, proceed with caution.
Extreme caution. You'll be constantly titrating this slowly because increasing serum sodium too quickly, more than about 8 to 12 NEQL in 24 hours, can cause irreversible brain damage. Osmotic demyelination syndrome.
Wow. Okay, so slow and steady.
It's truly a tightrope walk. And of course, seizure and fall precautions are essential, plus meticulous monitoring, intake and output, daily weights, and neurological status, often hourly in acute phases.
Makes sense. Now let's flip that entirely. If SIADH is too much ADH, what happens when there's too little ADH? Or maybe the kidneys just don't respond to it. What kind of emergency are we looking at there?
That's diabetes insipidus, or DI.
Oh, yeah.
And yeah, it's like the kidneys have completely lost their stop button for water excretion. You either have a deficient production or secretion of ADH from the pituitary that's central DI, or the kidneys just aren't responding to the ADH that's there that's nephrogenic DI. Either way, the body is rapidly losing massive amounts of pure water, leading to severe fluid and electrolyte imbalances.
Okay, so instead of fluid retention, we're talking massive fluid loss. What are the hallmark signs a nurse would be looking for? What really screams water wasting with DI?
The key features are intense polydipsia, that's excessive thirst, and dramatic polyuria,
Polyuria meaning?
massive urine output.
Yeah.
Patients can literally excrete anywhere from 2 to 20 liters of incredibly dilute urine per day.
20 liters? That's unbelievable.
It is. We're talking very low urine-specific gravity, often less than 1.005. This huge water loss leads to hypernatremia, high sodium, because it's pure water deficit. And patients can quickly become severely dehydrated. You'll see hypotension, tachycardia, and if it's not managed quickly, even hypovolemic shock.
And high sodium is dangerous too.
Very. Uncorrected hypernatremia can actually cause brain shrinkage, so recognizing DI quickly is absolutely paramount.
Okay, considering this rapid and massive fluid loss in DI, how do nurses prioritize? What are the immediate threats we need to manage?
Maintaining adequate hydration. That is absolutely paramount. #1 priority. For central DI, the treatment of choice is usually DDAVP or desmopressin acetate. It's an ADH analog, basically hormone replacement.
How is that given?
It can be given orally, IV, subcutaneously, or even as a nasal spray. We're also aggressively replacing fluids, either orally if they can drink, or intravenously with hypotonic saline or D5W. And that IV fluid needs to be carefully titrated to match their urine output.
Okay, balancing act again?
Always. Now, for nephrogenic DI, since the kidneys don't respond to ADH, giving DDAVP won't work. Treatment there shifts more towards a low-sodium diet and sometimes thiazide diuretics, which paradoxically can help reduce urine flow in this specific situation.
Interesting.
And in acute DI cases, you're looking at hourly monitoring of blood pressure, heart rate, urine output, and specific gravities. Very intensive monitoring initially.
Got it. Okay, from the master gland, let's zoom over to the thyroid gland. I like to think of it as the body's metabolic maestro.
That's a great analogy.
It sets our internal pace, our energy thermostat, right? And when it's off, the effects are profound. We're talking about hyperthyroidism and hypothyroidism, two metabolic extremes with really starkly different patient presentations.
Precisely. And these are extremely common endocrine disorders you'll definitely encounter. Understanding the contrast between them is absolutely vital for nursing students. Your assessment skills are key here.
Okay, let's first dive into hyperthyroidism. This is where we have an overactive thyroid releasing too much T3 and T4. The source mentioned the most common form is Graves' disease. What's actually happening in a patient with Graves to create this state of overdrive?
Right. Graves' disease is an autoimmune condition. Essentially, the body's own antibodies mistakenly attack the thyroid gland, but instead of destroying it, they stimulate it.
Oh, okay, so they rev it up.
Exactly. They trick the TSH receptors, causing the thyroid to release excessive amounts of thyroid hormones, T3 and T4. This leads to a systemic state of hypermetabolism, where basically everything in the body is running in fast forward.
So if the body's in this metabolic overdrive, how would that typically present? What kind of symptoms would a patient have, and what visible clues might you spot as a nurse?
Patients are often intolerant to heat, constantly feeling hot and sweating. They usually experience significant weight loss despite often having an increased appetite. They're eating more, but still losing weight.
That must be alarming for them.
Very. You'll also see signs of increased sympathetic nervous system stimulation. A racing heart, maybe a bounding pulse, sometimes dysrhythmias. They might seem nervous, extremely irritable, anxious, and often have fine tremors, especially noticeable in their hands when outstretched. A goiter, which is a visibly enlarged thyroid gland, is very common, and if you listen over it with a stethoscope, You might even hear bruits, like a whooshing sound due to the increased blood flow.
Okay.
And then there's a classic finding specifically in Graves' disease called exophthalmos.
Right, the bulging eyes.
Exactly. It's caused by increased fat deposits and fluid in the orbital tissues behind the eyes, causing the eyeballs to protrude. So, picture a patient who maybe can't sit still, is sweating, looks flushed, complains of palpitations, is hungry but losing weight, and looks a bit wide-eyed or startled.
Got it. Now, beyond these pretty intense symptoms, what's that one really urgent, life-threatening complication that can spiral out of control if a nurse isn't vigilant with a hyperthyroid patient?
Absolutely. You need to be watching for acute thyrotoxicosis, often called a thyroid storm.
Thyroid storm. Sounds serious.
It is. It's a life-threatening emergency.
Mm.
Basically, all the hyperthyroid symptoms are magnified to an extreme degree. You see severe tachycardia that can quickly lead to heart failure, hyperthermia temperatures soaring up to 106 degrees Saris Quora, or even higher extreme agitation, restlessness, delirium, vomiting, diarrhea, and even seizures or coma. It's a true medical crisis requiring immediate and aggressive intervention.
Wow. Okay, so given these profound symptoms and the risk of storm, what are our key nursing interventions for hyperthyroidism? And specifically, if a patient needs surgery, like a subtotal thyroidectomy, what are the critical post-op assessments?
Treatment generally aims to block that excess hormone production and manage the intense symptoms. So antithyroid drugs like methimazole or propylthyrosol, PTU, are commonly used. We also use iodine solutions like Lugol solution or SSKI. These are often given through a straw because they can stain teeth. They help block hormone release and also decrease the gland's vascularity before surgery, making it safer.
And what about the heart symptoms?
Beta blockers like propranolol are crucial. They don't fix the thyroid problem itself, but they help manage the tachycardia, nervousness, and tremors caused by the excess thyroid hormone.
Okay, and post-op thyroidectomy?
Post-op care is intensely focused. Your absolute priorities include monitoring for airway obstruction. There can be swelling or laryngeal nerve damage. Hemorrhage is another risk due to the gland's vascularity. And critically, you need to watch for signs of hypocalcemia.
Why hypocalcemia?
Because the tiny parathyroid glands, which regulate calcium, sit right behind the thyroid. They can be inadvertently removed or damaged during surgery.
Ah, okay. And how would that show up?
It would present as tetany, muscle spasms, twitching. You check for a positive Schwastek's sign, which is facial muscle twitching when you tap the facial nerve, and Trousseau's sign, a carpal spasm when a blood pressure cuff is inflated on the arm.
So you need calcium ready.
Absolutely. Always have IV calcium gluconate immediately available at the bedside post-thyroidectomy. And you'd also encourage a high-calorie, high-protein diet to meet their incredibly increased metabolic demands during recovery and healing.
Makes sense. Now let's swing completely the other way. Hypothyroidism, a deficiency of thyroid hormone. If everything's slowing down systemically, what's often the root cause?
Well, primary hypothyroidism, the most common type, is usually caused by autoimmune destruction of the thyroid gland itself. The classic example is Hashimoto thyroiditis. It can also happen after treatments for hyperthyroidism, like a thyroidectomy or radioactive iodine therapy, which intentionally damage or destroy thyroid tissue. Essentially, this deficiency causes a generalized slowing of the entire body's metabolic rate.
So if everything's truly slowing down, what are the key clues we'll see? How does this present physically and mentally?
Patients will typically complain of feeling persistently tired, lethargic, just having no energy. They often gain weight easily, even if they aren't eating more, and have a profound intolerance to cold. They're always feeling chilly. You'll notice personality and mental changes too, like impaired memory, slowed speech, maybe decreased initiative or appearing depressed. Their physical appearance changes too.
How so?
A hallmark finding is something called myxedema. This isn't like typical pitting edema from fluid overload. It's an accumulation of hydrophilic mucopolysaccharides in the dermis and other tissues. This leads to puffiness, especially around the eyes, periorbital edema, and often a mask-like expressionless affect. Their skin will likely be dry and coarse, hair might be thin and brittle, nails thick. They truly look and feel slowed down.
Okay. And similar to thyroid storm for hyperthyroidism, is there a severe emergency complication for hypothyroidism?
Yes, there is. It's called myxedema coma.
Myxedema coma.
Exactly. And it's a medical emergency. It's characterized by dangerously low body temperature, hypothermia, hypotension, and hypoventilation. It can rapidly progress to cardiovascular collapse if not treated urgently. It's often triggered by something like an infection, exposure to cold, or certain drugs like opioids or sedatives in a patient with severe, long-standing, untreated hyperthyroidism.
Got it. So, what are our absolute priorities for nursing care when managing a patient with hypothyroidism, particularly thinking about lifelong management and medication?
The cornerstone of treatment is lifelong hormone replacement therapy with levothyroxine, which is synthetic T4. The common brand name is Synthroid. Patient teaching here is absolutely crucial. You need to emphasize taking this medication consistently, usually in the morning on an empty stomach, at least 30-60 minutes before breakfast, and at the same time every day.
And they can't just stop taking it.
Never. They must understand it's lifelong, and they should never stop it abruptly or change the dose without consulting their provider. Also, for patients who have underlying heart conditions, we start with very low doses of levothyroxine and increase it gradually.
Why is that?
Because suddenly increasing their metabolic rate can put a significant strain on the heart, potentially causing angina or dysrhythmias. So careful monitoring is key in those patients. For myxedema coma, the priorities are supporting vital functions immediately, airway, breathing, circulation, warming them up carefully, and giving IV thyroid hormone replacement. And ongoing patient education includes teaching them how to prevent skin breakdown due to dryness, and importantly, how to recognize the symptoms of both underdosing, hypothyroidism symptoms returning, and overdosing, which would look like hyperthyroidism. They need to understand that full spectrum.
Right, finding that balance again. Okay, our final stop on this deep dive takes us to the adrenal glands, specifically the cortex, which pumps out those critical corticosteroids. And here again, we see two contrasting conditions, Cushing's syndrome and Addison disease. It almost feels like the body's stress response system is either stuck on high alert or completely offline. Is that a fair way to think about it?
That's an excellent way to frame it, actually. These conditions really do represent a crucial clinical distinction between too much versus too little of these vital hormones, glucocorticoids, mineralocorticoids, and androgens. And yes, they directly impact the body's stress response, fluid balance, metabolism, and immune function.
So let's start with Cushing's syndrome. This is all about chronic exposure to excess corticosteroids. From a nursing perspective, what's the most common cause you'll actually encounter in clinical practice, and what are the less common sort of internal reasons?
By far, the most common cause you'll see day-to-day is iatrogenic, meaning it's caused by medical treatment.
Like giving steroids.
Exactly. Usually, it's the long-term administration of exogenous corticosteroids, like prednisone. For other medical conditions, think asthma, rheumatoid arthritis, autoimmune diseases, organ transplants. Endogenous causes where the body itself is overproducing are less common. These include an ACTH-secreting pituitary adenoma. That specific situation is actually called Cushing disease, or, less frequently, adrenal tumors that are pumping out excess cortisol on their own.
Okay. And this chronic excess steroid exposure leads to some really distinctive physical changes, doesn't it? What are those hallmark signs we should recognize, and what do they mean for the patient beyond just how they look?
Oh, absolutely.
Mm.
It leads to a very recognizable constellation of symptoms. We often see central or truncal obesity, where fat accumulates in the trunk, but the arms and legs might be thin. There's the classic rounded moon face, and also a buffalo hump, which is a collection of fat on the back of the neck and shoulders.
Right. Those are very visual cues.
They are, and the skin becomes thin, fragile, and bruises very easily. You often see purplish-red striae, like stretch marks, on the abdomen, breasts, and buttocks because the skin is just so fragile. Patients will also likely experience hyperglycemia because cortisol raises blood sugar. Muscle weakness and wasting occur due to protein catabolism. And hypertension is common due to the mineralocorticoid effects causing sodium and water retention.
So it's much more than cosmetic.
Much more. These changes impact mobility, dramatically increase their risk of infection because cortisol suppresses the immune system, can affect bone density leading to osteoporosis, and cause significant psychological distress and body image issues.
Understandable. So what are we doing as nurses to manage a patient with Cushing's syndrome? How do we help address the hormone levels and also support them through these really challenging physical and emotional changes?
Well, our main goals are to normalize that hormone secretion if possible and prevent complications. If the cause is exogenous steroids, the key is a gradual tapering of the medication. You can never stop steroids abruptly, as that can cause an adrenal crisis. The tapering has to be done very slowly under medical supervision.
Okay, slow taper is critical.
Absolutely. If the cause is a tumor, then surgery is usually the primary treatment. That might be a transsphenoidal removal for a pituitary adenoma or an adrenalectomy for an adrenal tumor. Nursing care involves meticulous monitoring of vital signs, especially blood pressure. Closely monitoring blood glucose levels is essential, and you have to be incredibly vigilant for signs of infection, because their inflammatory response is suppressed, so classic signs like fever might be masked.
Good point.
Emotional support is also really critical. These body image changes can be devastating, so acknowledging that and providing support is huge. And post-adrenalectomy, you're watching very carefully for blood pressure instability, fluid and electrolyte imbalances, and ensuring precise administration and tapering of IV corticosteroids because their remaining adrenal gland might be suppressed and slow to wake up.
Right. Okay, now on the complete opposite side, we have Addison disease. This is where the adrenal cortex isn't producing enough hormones. What's typically the main culprit behind those offline adrenal response, causing a deficiency in all three classes of adrenal corticosteroids.
In the developed world, specifically the U.S., up to 80% of cases are caused by an autoimmune response. The body's immune system mistakenly attacks and progressively destroys the adrenal cortex. It can also be triggered by other things, like tuberculosis, though less common now, fungal infections, hemorrhage into the adrenals, or metastatic cancer. And importantly, it can be caused by the sudden withdrawal of long-term corticosteroid therapy, which again highlights why gradual tapering is so vital.
Right.
What's crucial to remember with Addison's is that all three classes of adrenal corticosteroids, glucocorticoids like cortisol, mineralocorticoids like aldosterone, and androgens, are reduced or absent.
Okay, so it's a global adrenal insufficiency. What are the key signs that immediately signal Addison's to you as a nurse? Is there one really striking feature that's maybe often overlooked but tells you a lot?
The manifestations often have a really slow, insidious onset, which can make diagnosis tricky early on. Patients report things like progressive weakness, profound fatigue, maybe unintended weight loss, and anorexia. But perhaps the most striking feature, and often the one that's overlooked by the patient initially until it's quite pronounced, is a bronzed or smoky hyperpigmentation of the skin.
Hyperpigmentation, like a tan.
Sort of, but it's different.
Huh.
It's often most noticeable in sun-exposed areas, but also over pressure points like elbows and knees, and importantly in skin creases like the lines on the palms, and sometimes even on the gums or mucous membranes.
Why does that happen?
It's due to increased secretion of ACTH from the pituitary gland, trying desperately to stimulate the failing adrenal glands. A precursor molecule to ACTH also stimulates melanocytes, the pigment-producing cells in the skin.
Fascinating. What else?
Patients may also experience orthostatic hypotension, feeling dizzy or faint when standing up due to low aldosterone and volume depletion, and often report an intense craving for salt, again, because of the lack of aldosterone.
Got it. And the complication for Addison's, the equivalent of thyroid storm or myxedema coma, is the Addisonian crisis, right? How dangerous is that?
Yes, an Addisonian crisis is absolutely a life-threatening emergency. It can be triggered by severe stress, like trauma, surgery, or a significant infection in someone with Addison's, or by the sudden, abrupt withdrawal of corticosteroid therapy in someone whose adrenals are suppressed. This leads to a rapid onset of severe symptoms. Profound hypotension, potentially leading to shock, tachycardia, severe dehydration, hyponatremia, hyperkalemia, hypotassium, which is dangerous for the heart, and hypoglycemia. It's a true medical emergency requiring aggressive, immediate management to prevent circulatory collapse and death.
Wow. Okay, so given the life-threatening nature of an Addisonian crisis and the need for lifelong management, what are the absolute nursing priorities for someone diagnosed with Addison disease, especially focusing on patient education and emergency preparedness?
Lifelong hormone replacement therapy is the absolute mainstay. This typically involves replacing both glucocorticoids, usually with hydrocortisone, which also has some mineralocorticoid activity, and mineralocorticoids with fludrocortisone. A critical teaching point one you'll probably repeat many times is that patients must learn to increase their glucocorticoid, hydrocortisone dosage during times of physical stress.
Like what kind of stress?
Like fever, significant infection, trauma, surgery, even sometimes significant emotional stress. They need clear instructions on stress dosing or sick day rules to prevent an Addisonian crisis. Usually they double or triple their usual dose temporarily.
That sounds vile.
It is life-saving knowledge for them. They should also be taught how to use and always carry an emergency intramuscular hydrocortisone injection kit, and they should wear a medical loop bracelet or necklace identifying them as having adrenal insufficiency.
Okay. And in a crisis?
Nursing care during an Addisonian crisis focuses on shock management, immediate administration of high-dose IV hydrocortisone, and aggressive IV fluid replacement, usually with saline and dextrose solutions, to restore volume and correct electrolyte imbalances. And just like with hypothyroidism, ongoing teaching includes helping patients monitor for signs of both underdosing, Addison symptoms, and overdosing, which would look like Cushing syndrome symptoms. It's about maintaining that hormonal balance long term. If we just step back for a second and connect this to the bigger picture, so many patients in healthcare, for all sorts of reasons, are on exogenous corticosteroid therapy. Think asthma, COPD, arthritis, IBD, transplant.
Right, it's incredibly common.
Exactly. So, beyond just Cushing's and Addison's disease, understanding the general effects and side effects of corticosteroids is crucial for basically every nurse. Yes, they effectively suppress inflammation, which is why we use them, but in doing so, they significantly increase the risk of infection and can mask its signs. They can cause glucose intolerance or worsen diabetes. They often cause hypertension, fluid retention, and can lead to osteoporosis with long-term use. Mood changes, insomnia. The list is long.
So patient teaching is key for anyone on steroids.
Absolutely essential. Emphasizing never, ever abruptly stopping these drugs. Teaching them to take their dose in the morning with food to mimic the body's natural cortisol rhythm and minimize GI upset. Encouraging regular blood glucose monitoring if indicated. Discussing the need for a diet potentially higher in protein, calcium, and potassium, but maybe lower in sodium depending on the situation, is comprehensive teaching.
Wow, okay. We've really covered some significant ground today. From the pituitary's really delicate fluid balance act to the thyroid's metabolic thermostat control and the adrenal gland's vital stress hormones. Reflecting on all of that, what stands out to you as maybe the key conceptual takeaway from this entire deep dive into these endocrine contrasts?
For me, I think the key insight, the thing to really internalize, is to always think in terms of balance and extremes. These endocrine conditions are often like a hormonal seesaw that's tipped too far, one way or the other.
Yeah.
Your nursing role is so critical in identifying which way is tipping too high or too low, and then anticipating the entire cascade of physiological problems that will follow that imbalance.
Isn't the whole picture?
Exactly. It's about seeing the patterns, understanding the underlying physiology, and connecting the systemic effects, not just looking at isolated symptoms like high heart rate or low sodium. This ability to connect those dots, to understand the why behind the symptoms based on the hormone imbalance, is what makes you a truly effective nurse. And frankly, it's exactly the kind of critical thinking that will serve you well on the NCLEX and in your practice.
That's a really powerful way to frame it. Thinking about that balance and the lifelong nature of many of these. So as you listening integrate this knowledge, maybe consider this. Beyond the acute phases and the immediate management we discussed, how might the chronic nature of all these endocrine conditions needing lifelong medication, regular monitoring, potential lifestyle changes, how might that impact a patient's overall quality of life, their mental health, their ability to adhere to complex treatment regimens, and perhaps most importantly, what ongoing support can you, as their future nurse, provide to truly empower them in their self-management journey over the long haul? That's it for another deep dive. Keep learning, keep questioning, and keep making a profound difference in your patients' lives. We'll catch you next time.